Hyperthyroidism. Graves' disease. Hyperthyroidism, thyrotoxicosis, hypermetabolic condition. FT4, FT3, or both. Hyperthyroidism. Subset of thyrotoxicosis excludes exogenous thyroid hormone intake and subacute thyroiditis. Excess synthesis and secretion of thyroid hormone by the thyroid. Common forms, 85 to 90% of cases. Radioactive iodine uptake over neck. Diffuse toxic goiter, Graves' disease, 50 to 60%. Increased toxic multinodular goiter, Plummer disease. Thyrotoxic phase of subacute thyroiditis. Decreased toxic adenoma. Less common forms. Iodine-induced thyrotoxicosis. Variable. Excess human chorionic gonadotropin, molar pregnancy/choriocarcinoma. Decreased thyrotoxicosis factitia. Uncommon forms. Pituitary tumors producing thyroid-stimulating hormone. Increased pituitary resistance to thyroid hormone. Metastatic thyroid carcinoma. Decreased struma ovarii with thyrotoxicosis. Graves' disease. In 1835, Dr. Robert Graves. Signs and symptoms: anxiety, weight loss, despite normal food intake. Irritability. Difficulty sleeping. A rapid or irregular heartbeat. A fine tremor of your hands or fingers. An increase in perspiration. Sensitivity to heat. Weight loss, despite normal food intake. Brittle hair. Enlargement of your thyroid gland, goiter. Light menstrual periods. Frequent bowel movements. Graves' ophthalmopathy. Excess tearing and sensation of grit or sand in either or both eyes. Reddened or inflamed eyes. Widening of the space between your eyelids. Swelling of the lids and tissues around the eyes. Light sensitivity. Less often. Ulcers on the cornea. Double vision. Limited eye movements. Blurred or reduced vision. Graves' dermopathy. Results from a buildup of protein in the skin. Pathophysiology: B and T lymphocyte-mediated autoimmunity. For well-known thyroid antigens, thyroglobulin, thyroperoxidase, sodium iodide symporter, TSH receptor. TSH receptor antibody. Immunoglobulin G1, IG1, subclass. Pituitary TSH. Release of thyroid hormone and thyroglobulin. Iodine uptake, protein synthesis, and growth in the thyroid gland by CAMP. Besides being the source of autoantigens, the thyroid cells express molecules that mediate T-cell adhesion and complement regulation, FAS and cytokines, that participate and interact with the immune system. Mortality/morbidity if untreated. Life-threatening thyrotoxic crisis, thyroid storm. Severe weight loss with catabolism of bone and muscle. Cardiac complications and psychocognitive complications. Osteoporosis. Neonatal hyperthyroidism. Elderly PT, apathetic hyperthyroidism. Unexplained weight loss or cardiac symptoms such as atrial fibrillation and congestive heart failure. Ophthalmopathy. Acropathy. Lab studies: subnormal or suppressed TSH levels, free T4, T3. TSH receptor antibody, TSI, diagnostic. Others: antithyroglobulin antibody, antithyroidal peroxidase antibody, thyrotropin receptor blocking antibodies, antisodium iodide symporter antibody. Imaging studies. Radioactive iodine scanning, 123I radionuclide scan, diffuse uptake through an enlarged gland. Ultrasound. CT scan or MRI, of orbits. Tau columnar thyroid epithelium lines the hyperplastic and foldings into the colloid. clear vacuoles in the colloid next to the epithelium where the increased activity of the epithelium to produce increased thyroid hormone. Prominent enfoldings of the hyperplastic epithelium. Treatment. Medication, antithyroid drug. Radioiodine ablation. Surgery, antithyroid drugs. Thioamides, inhibiting iodide organification and coupling processes preventing synthesis of thyroid hormones. Propylthiouracil PTU, versus methimazole MIS, major congenital malformation incidence, PTU, 3%, versus MIS 2.7%, cf. Normal background rate 2-5%, duration and doses, 0-23 weeks, 100 to 600 mg/d of PTU or 10 to 60 mg/d of mount, agranulocytosis, 0.2-0.5%, PTU, transaminase and susceptible individual MIS, cholestatic. PTU versus MIS, which drug is more effective? MIS 10 mg Tiden equals 66 versus PTU 100 mg Tiden equals 17. MZ, more rapid normalization of TFT. N equals 29, PTU 100 mg Td versus MIS 30 mg QD. MZ, more rapid normalization of FT4 and T3. N equals 94, MIS 10 mg Q12, 8, 6 hours versus PTU 100 mg Q12, 8, 6 hours, for 12 weeks. Term efficacy was equivalent. N equals 71, MIS 15 mg/d versus PTU 150 mg/d for 12 weeks. MIS group, lower FT4 and T3 at every time point. Euthyroid at 12 weeks, MIS 77% versus PTU 19%. PTU versus MIS, which drug is less toxic? Minor reaction. Rash, urticaria, arthralgia, gastric intolerance. No statistically different. MZ, dose-related MIS 5 to 10 mg/d, fewer SE. Major reaction. Agranulocytosis, 0.2-0.5%, lesser with MIS less than 10 mg/d. Drug-induced hepatitis, PTU exclusively. Oncopositive vasculitis, PTU exclusively. Conclusion. MIS is safer, especially dose below 10 mg/d, PTU versus MIS, which drug is associated with greater patient compliance. MIS 30 mg/d versus PTU 100 mg get after 3 months. 83% versus 53%. PTU versus MIS, which drug costs less? PTU 300 mg/d, $21.81 per month. MIS 30 mg/d, $62.30 per month. Dose. MIS 10 mg equals PTU 300 mg. KIMS. MIS 5 mg, 39/t, 21-22/t. PTU 50 mg, 30/t, 24-30/t. What are the effects of PTU and MIS on the efficacy of subsequent radioactive iodine therapy? MIS, no alteration in the effectiveness of radioactive iodine therapy. PTU, the dose radioactive iodine could be increased by 25% to overcome the putative radio-resistant effects of PTU. How long should a patient be treated to maximize the chances of remission? Remission rate. Higher with more than 2 years than 1 year. Relapse rates. 6 months greater than 18 months. No difference. 12 versus 24. 6 versus 12. 18 versus 42. Conclusion. Treatment longer than 12 to 18 months not yield higher remission rates compared with longer treatment periods. Does the antithyroid drug dose influence the chances of remission? High dose plus T4 or T3 versus low dose. No significant difference in remission rates. High dose with more side effects. How much antithyroid drug dose should be used initially? Euthyroid within 3 weeks and 6 weeks. Ms 10 mg/d, 68%, 85%. Ms 40 mg/d, 83%, 92%. Carbimazole. More severe, T4 greater than 21 micrograms/d, CBZ 40 mg, Ms 30 mg. Less severe, T4 greater than 21 micrograms/d, CBZ 20 mg, Ms 15 mg. Conclusion. Underlying DS activity and starting dose are both important. Mild to moderate DS, Ms 10 to 20 mg. Radioiodine ablation in 1941, Massachusetts General Hospital. Hyperthyroidism 131I, 127I, 131I. Tellurium dioxide or xenon. 131I greater than 2. 131I, effective half-life, Te. 1/Te equals 1/Tp plus 1/Tb. TP equals 8.02. TB. Or 131I 1 gram 1% versus 1 gram 0.001 tilde 0.5%. 4000 5000. 131I. 1 tilde 2 millimeters. 8. 131I. Ten. 10-6, 3. 1. 1. 231, free radical scavenger. 5150 grays, 5000 15000 rad, 515 MC. MC, equals, 80 to 120 UC/G of thyroid, estimated thyroid weight G, 24-hour RAU, less than 50%, -A, 8, or, 25%, or, -A, or, -A-TSH receptor antibody, 1, 6, 8, 50 tilde 75%, 80 tilde 90%, 110 tilde 20%, 6 or 1, 110 tilde 40%, 90%, 2 tilde 3%, 90%, 1/3, 214, rare R, or rare, not associated, surgery, equals 80 tilde 90%. Indication of surgery in patients with Graves' disease. Large goiter. Resistance to antithyroid therapy. Side effect of antithyroid drug. Desire to rapid healing. Inaccessibility to regular medical care. Goiter with neoplasm. Fear to radioisotopy. Patients who want to high accessibility. Others. Purpose of preoperative preparation. Maintain normal thyroid hormone level. Normalize activated sympathetic nerve system. Normalize increased metabolic rate. Decreased blood loss during operation. Decreased duration of preoperative preparation. Minimize side effects and easy to take, preoperative preparation. Propranolol. Propranolol plus PTU. Propranolol plus PT plus Lugol solution. PT plus Lugol solution. PT plus thyroid hormone plus Lugol solution. Propranolol plus Lugol solution. Dexamethasone. PTU, T4 T3, TSH receptor antibody, 2 hormone 30%, 4, type of operation in Graves' disease. Bilateral subtotal thyroidectomy. Lobectomy plus contralateral subtotal thyroidectomy. Total thyroidectomy. 5 tilde 10 grams. 80 tilde 94%.